presentation. So the next presentation will be given by Professor Vincenzo Leuzzi and Dr. Serena Galosi. Professor Leuzzi is a professor and the chair of the Child Neurology and Psychiatry Department at Sapienza University of Rome. He is also the head of the Clinical Center for Neonatal Screening in the Italian region of Lazio. Professor Leuzzi has been involved for over 30 years in the study of pediatric neurogenics and neurometabolic movement disorders, with over 200 publications in these fields. Dr. Galosi finished her medical residency in child neurology and psychiatry and her PhD in clinical and experimental neuroscience at Sapienza University of Rome. She was a research fellow in the Pediatric Movement Disorders Clinic and the Center for Genomic Medicine at the University of California in San Diego and Rady Children's Hospital. Dr. Galosi is currently a pediatric neurologist in the Department of Human Neuroscience at Sapienza University with a focus in genetic pediatric movement disorders. Professor Leuzzi and Dr. Galosi are collaborating authors on two GNAO1 articles published in 2017 in Neurology Genetics and 2018 in Parkinsonism and Related Disorders. They are currently collaborating as clinical advisors in the research study presented by Simone Martinelli and Martina Di Rocco. They will be presenting an update on the clinical spectrum of GNAO1 related disorders. After hearing the first two presentations, which obviously came from the US, I think it will be very interesting for all attending to hear also a little bit more of the clinical spectrum in Europe. Thank you.
Hello, I'm going to share my screen. Okay. Do you see my screen?
We cannot.
You can. Why? Now?
Yes.
Okay. So, hello everyone. First, I want to thank the organizer for the opportunity to participate to this nice conference dedicated to GNAO1. Today, we are going to cover 4 topics, which are the clinical spectrum and movement disorder phenomenology of this condition, the presenting signs, some data about neuroimaging findings, and genotype-phenotype correlation. Let's start with an historical perspective. The gene was first associated with human disease 7 years ago by the Japanese group of Nakamura and colleagues, and they described GNAO1 pathogenic variants in 4 children with Hotara syndromes. 2 of them had involuntary movement. 3 years later, the same group reported the first patients with prominent movement disorder phenotypes. And in 2015, in parallel, Kulkarni published the first 2 brothers treated with DPS for severe movement exacerbations. And they described for the first time how intercurrent illnesses could trigger movement disorder. In recent years, we have learned how G-alpha protein is part of a complex network of proteins involved in C-hemp synthesis. This is a pathway which is highly active and expressed in striatal medium spiny neurons. And all this gene can cause early onset hyperkinetic movement disorders with chorea and facial dyskinesia in a few of them. I just want to show you a few videos of these other conditions. This is the mild phenotype of DCY5 mutation, the first family described. And here we see the GNAO1, the ADCY5 most severe mutation, and you can see how these movements are similar of the movements that we see in GNAO1. And here another patient with the ADCY5, same mutation of the patient with the severe phenotype we saw before, but we see that the phenotype of this child is milder, and this happens in this rare movement disorder. There is axial hypotonia that we see also in GNAO1. Exercise-induced dyskinesia and kinesiogenic dyskinesia. In this condition, there is a wide range of paroxysmal movements. And interestingly, there are these nocturnal spells of movement disorder. And we heard before from Dr. Biover that, and also in my clinical practice, I realized that also GNAO1 patients can have nocturnal movement disorder. GMB1, this is another G protein and is this gene, the protein encoded by this gene works together, the G-alpha protein, and is part of the heterotrimeric structure of G proteins, and is a downstream effector of G protein coupled receptors. The first patient had been described in 2016 with a clinical phenotype that is very similar to the one seen in GNAO1. There is global developmental delay, severe infantile hypotonia, dystonia and dyskinesia with status dystonicus in some patients, and also the epilepsy spectrum is similar to the one seen in GNAO1. And most mutations are located in exon 6, 7 and involve the region where the beta protein interact with the G-alpha protein. And this is a video of a patient with a mild phenotype. And here we can see these kinetic movements. And this is this girl has a prominent dystonic movement disorder with axial hypotonia. Okay, but coming back to GNAO1, here we see the two phenotypes registered in OMIM, the epileptic encephalopathy phenotype and the neurodevelopmental disorder with involuntary movement. But we know that the clinical reality is much more complex. I think that there are at least 4 phenotypes. We can have the early onset epileptic encephalopathy manifesting with the HOTAR or West syndrome, or with malignant migrating partial epilepsy of infancy. We can have an epilepsy of variable severity, often well controlled with movement disorder. We can have movement disorder without seizures, and we can have a neurodevelopmental disorder with dyskinesia later in the disease course. All these phenotypes have central hypotonia and developmental delay. I'm sorry. Okay. Just to see a few numbers, about 60% of patients 60 to 70 have a movement disorder characterized by chorea and dystonia. 40% have epilepsy, and only 20% of patients have a severe form of epilepsy. In the last few years, movement disorder phenomenology has been well characterized. We know that the typical onset of movement disorder in this condition is in the first 2 years of life, with a wide range going to 3 months to the second decade of life. There are cases that have onset of movement disorder, of the paroxysmal movement disorder, around 10, 12 years of age. Hypotonia and developmental delay are very frequent. The movement disorder is characterized by an association of chorea and dystonia. We can see facial dyskinesia or complex motor stereotypies. At the beginning, when movement disorder onset, usually there aren't paroxysmal episode, but an action-induced movement disorder. Paroxysmal episodes can be severe, can be life-threatening, can evolve into status dystonicus, and can last minutes to days or even weeks or months. Triggers are very important. We're going to see a number of them in the next slide. And in our clinical practice, we observed an ocular movement disorder. These children can have conjugate ocular movement abnormalities in the horizontal or in the vertical plane. When they are in the vertical plane, they look like oculogyric crisis, but we don't know if they really are oculogyric crisis. Triggers. I review the literature looking for all the possible triggers, and I review the medical records of our patients, and emotion, both negative or positive emotions are important triggers for paroxysmal episode. Infections, intercurrent illnesses with or without fever, pain, high ambient temperature. We observe a worsening of the baseline movement disorder and paroxysmal events during summer. During summer, there is also dehydration. So I have to say that maybe summer is not a good period for GNAO1 patients. Also, change of positioning, voluntary movement, and the intention to move can cause paroxysmal, can start paroxysmal movement disorder. And interesting for girl, menstruation is another trigger for paroxysmal episodes. During movement disorder exacerbation, but maybe also outside movement disorder exacerbation, there is an autonomic instability characterized by tachycardia, hypertension, intense sweating, and hyperthermia. There are patients who presented neuroleptic malignant syndrome with thiaprid, haloperidol. So haloperidol, I think, could be an effective medication for this patient, but we have to be aware of this complication. So I ask, the question is when we should screen a child for GNAO1 mutation. What is the typical onset of this condition? We reviewing literature and in our clinical practice, we realized that there are three main motor patterns and three main presentations of this condition. The more frequent is the typical hyperkinetic form. These children in an adult period can have hyperexcitability, startle reflexes, apneic episodes, feeding difficulties. All these children in the first month, because this is an early condition, but not a congenital condition, so there could be a period, a free period. So in the first months of life, they show profound hypotonia, and they start to show signs of developmental delay, or after a period of normal development, there could be developmental stagnation or regression. The onset of abnormal movement disorder, of abnormal hyperkinetic movements, is within the first 2 years of life, often action-induced movement disorder without the severe exacerbation that start to happen later during childhood. If they are on the epileptic side, in the first 3 months, we can see infantile spasm with hypsarrhythmia or focal motor seizures. This is a more rare phenotype, but patients like this have been described. We call this phenotype the hypokinetic phenotype. These children have decreased spontaneous movement, severe axial hypotonia. There is a patient described by Okumura who had rest tremor. And these kinetic features are occasional with the hand or foot posturing, grimacing, and there seems to be a specific mutation associated with this phenotype. The last phenotype that we observe is the CP-like phenotype. These children present with motor with developmental delay with prominent motor delay. Hypotonia is present but is less severe. There is a baseline mild hyperkinetic movement disorder which is stable over time with some fluctuation, but what these children have is a sudden precipitation of their movement disorder, often under an intercurrent illness, an infection, and they can start with paroxysmal episodes at the age of 8, 9, 10 years. These children often achieve the independent working and language. Just to, I just want to give you some data about what is a cerebral palsy mimic. We call cerebral palsy mimic a clinical syndrome which is consistent with the cerebral palsy. But there is absence of a documented risk factor for cerebral palsy. With this syndrome onset before 2 years of age, the clinical course is stable and the neuroimaging is normal or non-specific. When we have this kind of presentation, but with the program at some point paroxysmal motor symptoms or new neurological symptoms appear, we should work up this patient, and GNAO1 is one of the conditions that we should look for. So this is an overview of the 3 phenotypes that I presented before. We can have in pink the early onset hyperkinetic phenotype with hyperkinetic features within the first 2 years of life and paroxysmal movement disorder from childhood. We can have the hypokinetic form with bradykinesia and decreased spontaneous movement and possibly later development of paroxysmal episodes. And we have the CP-like phenotype with an hyperkinetic movement disorder, stable over time, sudden precipitation, and paroxysmal movement disorder in late childhood. Going to neuroimaging, MRI scan was considered non-specific and with no major structural abnormalities in this condition. But reviewing literature we realized that there are 3 main features which are cortical atrophy, white matter abnormalities, and basal ganglia abnormalities that recur in this population. This is a child reported by Rachele Danti in his paper with a severe movement disorder phenotype and regression. And here we see this cortical atrophy, ventricular enlargement, and the small caudate nuclei and dysmorphic corpus callosum. Other 2 patients with severe movement disorder and epilepsy. Again, we have atrophy, ventricular enlargement, and hypoplasia of the caudate nuclei and thinning of the corpus callosum. Here, 2 children reported by Dr. Coyne in 2018 with severe movement disorder phenotype and bilateral hypointensities of the globus pallidus, and again cortical and subcortical atrophy. bilateral hyperintensities of the thalami in the same paper published by Dr. Coy. And this is a girl with a severe epileptic encephalopathy, and we have a repetitive, we have a MRI performed over time. And again, we see the frontal lobe volume reduction, mild cortical atrophy. There is this enlargement of temporal spaces, which is frequent in GNAO1 patients, hypomyelination, thinning of the corpus callosum, and basal ganglia atrophy. Talking about genotype-phenotype correlation, the predicted protein structure of G-alpha consists of an helical domain and a catalytic domain with a GTPase binding pocket. This is associated residues localized into the catalytic domain. And since that variants associated with isolated movement disorder are found outside the catalytic pocket with the position 207 to 247, which are not spot for movement disorder. And any variant in or near, very close to the catalytic pocket can result in epilepsy alone or in association with a movement disorder. We review literature looking for phenotypic expansion. I have to say that there are very few cases with mild phenotype. I couldn't find adult onset cases. The patient with the milder phenotype reported in literature has been reported this year by Wirt and colleague, and is a patient with a 31-year patient with a non-progressive dystonia, normal MRI. His mother was similarly affected. And what about milder phenotypes? This is a gene with a high germline mosaicism rate. So there are mosaic parents and there are brothers affected by GNAO1. And mosaic parents can have a family history notable for febrile seizures. This is an interesting paper that came out this year on neurology, a series of 34 children with childhood apraxia of speech, a severe language disorder. And it's interesting that 11 of these patients had plausible pathogenetic variants in novel genes for childhood apraxia of speech. And in this list, there are both GNAO1 and GNB1. This is the patient with the GNAO1 mutation, is a 5-year-old child with a severe articulation disorder and bilateral temporal discharges. And I want to contribute with a personal case that we have seen a few months ago, a 5-year-old boy with a history of a single febrile seizure at the age of 2, and EEG characterized by multifocal epileptic discharges during sleep. His motor exam was completely normal. He had no seizure after the first episode. He has an expressive language disorder with 2 short periods of language regression and stuttering. The first episode after febrile episode, he has a de novo pathogenic variant, a stop variant. So going to my conclusion, we saw that GNAO1 is part of a complex network of proteins involved in movement disorder pathomechanism and encoded by genes showing overlapping phenotypes. Paroxysmal episodes and the specific range of triggers are typical of this condition. Diagnosis can be suspected based on 3 major motor patterns: the hyperkinetic, the hypokinetic, and CP-like phenotype. Neuroimaging was considered non-specific, but I think that can guide diagnosis of this condition because there are some recurring features. Except for specific residues, genotype-phenotype correlation is still poorly characterized, and we need reports of milder phenotypes in order to clarify the phenotypic spectrum. And thanks for your attention.
Thank you. These presentations so far have raised a lot of questions. So I'm going to ask this question, and then in addition, any of the previous speakers feel free to respond, as well as those who have not yet spoken. So the question, there are a couple of questions that have to do with sleep, because this is actually a very common concern with many of the parents of GNAO1 children. So one is sometimes the movement disorders prevent falling asleep. So it makes it much more difficult for the GNAO1 child, the patient, to fall asleep. And what is the best treatment for that? How can we, facilitate falling asleep?
I think that benzodiazepine can be useful both for inducing sleep and control of movement disorders. So maybe if the major issue is sleep, medication as clonazepam, lorazepam can be useful to induce sleep and control nighttime movement disorder if there are movement disorder during night.
I would probably agree with that. Especially if you can get away with just a very low dose of that, to calm the movement such that it doesn't keep waking up the child.
Okay, I think, and
I was going to just comment that from an occupational therapy standpoint, we use a lot of times sensory input. And so proprioceptive, which is kind of like a squeezing and hugging of the child, can help with sleep. And so weighted blankets sometimes are helpful with movement disorder kids to be able to settle them down. Again, I put a big, huge warning sign because weighted blankets can also inhibit movement. So if a child doesn't have a lot of good ability to roll or turn, that I wouldn't encourage use of it throughout the night. I would just use it while you're present to be able to help calm them enough to be able to fall asleep, because we do not want to restrict them to the point where they cannot turn over and breathe.
okay, and thank you. This second question has to do also with sleep. A lot of parents are concerned because going back to being able to distinguish between epileptic seizures and involuntary movements, especially in sleep, because obviously when the parents are sleeping and then you're woken up for some reason, it's extremely difficult to make a video or to tell the difference as when you're in a home context. So what is the recommendation around that? Because obviously if you're in a hospital stay, there's a lot of monitoring, but I think the concern arises when you're in a home context.
For treating these episodes, do you mean for treating episodes or to distinguish episodes?
I think both, because obviously first we have to be able to distinguish to know what should be done.
At home, I think that the most important things is to look at the duration of the episode. Intrarectal benzodiazepine can control both epilepsy and movement disorder in these patients. So this is an option for treatment. I think that an expert clinician could be able to distinguish from a clinical standpoint if we are looking at the movement disorder paroxysmal episode, which are very, the paroxysmal episodes of GNAO1 when we have movement disorder episode are typical. are correct, are ballistic, so we can distinguish them from seizures. When we have doubt about the nature of episodes, we need an overnight EEG to distinguish them.
Okay. I'm going to also, this is a comment from Dr. Lin, since he's in the audience. So he did say that one medication that that his team uses for sleep and dystonia dyskinesia as an alternative to benzodiazepam benzodiazepam is clonidine. And so this he said, particularly when there is difficulty in sitting and sleep quality. So I don't know if you have comments about that. This is a comment that Dr. Lin added to the Q&A.
Yeah, this is Dr. Vhover. I would agree with Dr. Lin's comment, especially if we're worried about secretions or respiratory issues. I think I use quite a bit of clonidine.
Mm-hmm. There are also, I saw a couple of questions pertaining to gastrointestinal difficulties or other, let's say, difficulties with constipation and passing and bowel movement. So is there, I think this is, there's a general comment, and there also, is this quite a general and common, I guess, concern for GNAO1 children?
So I can tell you from the natural history study, you know, in the kind of 44 patients that we've looked at, I don't remember the exact number, but I would say probably it's a severe concern in probably about 25% of the patients, and it can be quite severe to the point of needing both like a not just a normal gastronomy tube, but what we call a GJ tube, where it goes into the jejunum. And I will say that it's something that I often recommend that we stay, that we are very aggressive at treating, especially the constipation part. So constipation is a very common problem, not only in GNAO1, but in all children who have movement problems. But in GNAO1, it often can be a trigger for the chorea, either when the child is constipated, you know, especially in those children who have communication problems, but then also just having a bowel movement. I've heard parents tell me that every time the child has a bowel movement, their movements get out of control. So staying on top of that with aggressive management and keeping the stool soft, I think can be helpful, but also feeding, just problems with feeding from a gastric motility standpoint is also a problem that that's another area that we've thought about including our colleagues, in addition to sleep evaluations, is having the natural history subjects evaluated by a single GI specialist to try and understand, is it you know, our run-of-the-mill GI problems that we see in cerebral palsy, or is there something additional to that? Because it does seem to be, in certain cases, more severe than I see in the children that I treat with cerebral palsy.
And then there's a question around around the best treatment for status dystonicus. I mean, obviously there's DBS, but are there protocols, treatment protocols for status dystonicus?
So there are, and I would be careful in calling it status dystonicus, okay? Because most of the storms that we see in the kids that land them in the ICU are chorea and not dystonia. And that needs to be treated quite differently. Well, not quite differently. And oftentimes there's different treatments for that. And it is often labeled by status dystonicus because clinicians don't have another term for it. But I am in the process of trying to develop a flow sheet that we can distribute to clinicians for treating this. But the first line should be benzodiazepines. I prefer diazepam, but Ativan is probably okay too. And then aggressive management with either some sort of neuroleptic, risperidone or Haldol, with the caveat of looking for the neuromalignant syndrome, as Dr. Galosi said, and sometimes aggressive treatment with tetrabenazine. But I would be interested to hear what Dr. Galosi has to say
about tetrabenazine and about the treatment of status dystonicus. I mean, what we saw is that D2 blockers and tetrabenazine are not so useful during severe exacerbations. In these cases, midazolam is effective, and sometimes we have to resort to propofol to stop severe episodes. I think that tetrabenazine is the most effective medications in these patients, but is effective in the baseline management of movement disorder, not for severe exacerbation. This situation, we need high doses benzodiazepine or emergency DBS.
Mm-hmm.
Yeah.
There are several questions that pertaining to pharmacological therapies. I will ask those questions following the next presentation. So there is another question that has to do around speech regression. So what could be the reason for any regression in speech? And is there any connection with, pertaining to motor skills and the development or regression of motor skills?
This is not an easy question. We know that after severe episode, the GNAO1 patient can show a period of regression, especially motor regression, but also some parents report regression of cognitive skills, language. But there are patients who has a stepwise deterioration. So there are, with the repetition of paroxysmal episode, there is a regression that is not a temporary regression. We don't know at this point which are the patients that have progressive course of their condition, which mutation are more likely to give a progressive course of the disease. And we don't know if there is a correlation, for example, with the MRI scan. We don't have this data at this point.
I would agree with everything that Dr. Galosi said. I would also say that anytime there's a speech regression, and I would have a high suspicion to do an overnight EEG and make sure that there's not some sort of nocturnal epileptiform discharges, as kids with epilepsy can sometimes have that, and that can lead to speech regression.
Yeah.
I think there is a general, I guess, concern or question expressed around about the representation of actual patients with GNAO1, because I think there's, based on what we have heard in the last few days, some doubts about whether those patients who, there might be GNAO1 patients without epilepsy and without involuntary movements, and they're just not being reported and tested. So I think Dr. Lin, he added to the chat, and he made a suggestion. He personally thinks that all children with scan normal CP diagnoses should have GNAO1 screening as part of, as part of a movement disorders panel. So that addresses obviously those not yet diagnosed with GNAO1 but have fallen to the movement side. What is the general approach for diagnosing other GNAO1 patients? Because probably the spectrum, current reported spectrum, is probably skewed.
I would agree. And, you know, one of the things that when I'm teaching medical students and residents is they should not come to me and tell me that the child has cerebral palsy and not have a reason, or at least that we've looked for a reason. And I agree, every child that has quote unquote cerebral palsy and does not have a good explanation needs a test for not only GNAO1 but some of these other genetic causes. And unfortunately, unless children present to an academic medical center, they're often not getting the appropriate testing, because for years and years and years, cerebral palsy has been through, you know, people diagnose cerebral palsy and they kind of push it aside and say, oh, you've got cerebral palsy and we don't need to think about it anymore, you know? And so, at least from my perspective, I'm trying to change that through education, not only of, you know, medical students and residents, but also providers, you know, general pediatricians, and actually physical therapists, you know, because a lot of times, you know, it's the physical therapist who recognizes this is not the same as my other patients. So at least that's what I'm trying to do as a, you know, but I think as a community as well, raising awareness, you know.
Thank you so much.